Okay, the last speaker for this session is Dr. John Kinsella. And Dr. Kinsella is currently a professor of pediatrics at the University of Colorado. And he graduated from med school. He was at St. Louis University, and then did his neonatal fellowship at Wilford Hall, and then moved on to University of Colorado, where he's been ever since. Dr. Kinsella has done a lot of work on topics that are near and dear to my heart. I know pulmonary hypertension, hypoxic respiratory failure. He's been very active both as a researcher with animal models, clinical experiences, and also large randomized controlled trials. So it's really a pleasure to introduce him and listen to his discussion of cardiopulmonary interactions in CDH.
Thank you, Krista, and thanks, David, for inviting me. I am sensitive to the fact that we are supposed to be at lunch, and some people get hangry. I certainly do, so I'm going to skip some slides probably as we go through this and do it fairly quickly. I do have funding with an investigator-initiated grant from Mallinckrodt for a pH registry in the premature newborn. It's irrelevant to this talk. So, management of pulmonary hypertension in the infant with CDH is complicated by structural and functional changes in the heart, pulmonary circulation, airways, and lung parenchyma, and clearly optimal management strategies are a bit controversial. We tend to think of the management of CDH in different phases. First of all, the one I'm going to talk about this morning is the acute phase at birth, where severe hypoxemic respiratory failure is associated with intrapulmonary and extrapulmonary right-to-left shunting and shock. This is a slide I brought from Steve, which shows these striking structural changes in the pulmonary circulation of a newborn dying from diaphragmatic hernia. And in part because of that and what we know to be typical PPHN physiology with right-to-left shunting at the ductus arteriosus and across the oval foramen because of intense pulmonary arterial vasoconstriction, we have focused for a long time on better ways to manage pulmonary hypertension. In fact, we thought the early treatment immediately after delivery of PH in newborns with CDH should be a vital component of overall management. However, there is not compelling evidence for the early efficacy of pulmonary vasodilator drugs. And I think there's more to the story than pulmonary vasodilation alone, and I'll try to convince you of that in the next 20 minutes or so. So this is just sort of a history of interventions in newborns that have over time changed ECMO utilization. I point to, in the early 90s, the I know pilot trials, which caused a lot of interest in pulmonary vasodilation with inhaled nitric oxide. There was a randomized control of high-frequency oscillatory ventilation, which showed that as a rescue therapy, it could be particularly helpful in babies with severe parenchymal lung disease. The NENOS trial that Chris was involved with was published in 1997. There was also a randomized controlled trial of high-frequency and NO, showing that in some babies with parenchymal disease, optimizing NO delivery and efficacy was related to optimal lung recruitment. And that turned out to be a key part of our understanding of how to use this new therapy. There was a randomized controlled trial of surfactant, also showing that ECMO utilization could be reduced in a subset of babies who have parenchymal lung disease. Some of those babies born at or near term who truly did have RDS, and some with other diffuse parenchymal diseases like pneumonia responded well to surfactant. Synergy, the second pivotal trial that led to FDA approval, was published in 2000. And all of these things probably had a dramatic effect on ECMO utilization, beginning with 1991 with a peak of about 1,500 babies reported to the North American Registry, and a steady decline to about half of that over time. So it turns out that the babies getting better were probably babies with parenchymal lung disease, particularly babies with meconium aspiration syndrome. This just shows over from 1992 to 2015 the ratio of CDH to meconium aspiration syndrome babies treated with ECMO. By 2001, there are actually more babies with diaphragmatic hernia treated with ECMO than meconium aspiration. And if you look over this 10-year period, there essentially has been no change in ECMO utilization in North America. Now, if pulmonary hypertension is such a critical piece of that, what happens since the introduction of NO is the introduction of half a dozen other therapies, right? We're talking about prostanoids, both inhaled and IV. We're talking about phosphodiesterase inhibitors, endothelin antagonists. All of these things have been used in this population, but we essentially haven't changed ECMO utilization in 15 years. So if we think about the cardiopulmonary interactions in diaphragmatic hernia, of course, this key component of right-to-left shunting at the ductus and at times the foramen ovale, which is related to a relatively higher PVR to SVR, caused in part because of decreased lung volume and lung hypoplasia in CDH with decreased compliance and an intrapulmonary shunt, but also the pulmonary vascular, structural, and functional changes leading to severe pulmonary hypertension. And most importantly, I think now, and what I'm going to try to convince you of, is the LV with systolic and diastolic dysfunction and hypoplasia, which I think plays a critical role in our management of diaphragmatic hernia and something we're going to have to focus on. So this shows a right-to-left shunt of the ductus arteriosus, very common in babies with diaphragmatic hernia and other forms of PPHN. And what we typically think about in PPHN is a right-to-left shunt at the PFO. That makes some sense. You have suprasystemic pulmonary vascular resistance. You should shunt right to left across the ductus and the oval foramen. However, that atrial level shunt, remember, and the cardiologist will remind us of this, is not really a function of PVR and SVR, but really a function of LV and RV in diastolic volume and compliance. So if the LV is not working well, you can certainly see a left to right atrial level shunt in babies with CDH. This is an early baby that we treated years ago, a baby with diaphragmatic hernia who we treated with high frequency oscillation first and then treated with NO. This shows the oxygenation index. As you'll recall, it's a number that suggests how much work one needs to do to get a particular PO2 involving the mean airway pressure, the FiO2, and the PO2. This baby had a nice response. This is one of the very first cases we treated, so we were really interested in taking this investigational therapy away as soon as possible. We turned the NO off, and the baby's OI worsened, turned it back on, it got better, turned it off again, it worsened, but by about 3 days, we were able to take it away, and this baby went on to do really well. So we thought this was genius. We found this treatment for pulmonary hypertension. One of the problems with early successes with any intervention is it causes a kind of therapeutic imprinting. You're expecting to get that same result with every new therapy. This is one of the reasons, Chris, as I think will attest to, is that studying ECMO was so hard to do. Because if you had babies dying, and then, like in the late 80s in San Antonio, we were putting babies on ECMO, and suddenly you had a baby who's pink and hemodynamically stable, it's really hard in the next case to say, no, let's not do that. And so these things can have adverse effects as well, this kind of therapeutic imprinting, in that it makes it harder to think of other reasons why it's not working. But when you think about the evidence that we have, there's not a lot, right? But there were 2 small randomized controlled trials. In the largest study, the CDH subset, there were 53 babies randomized to treatment with NO or control early in their course, 13 hours versus 9 hours, quite sick by a postductal OI measurement, and I'll talk about this in a bit. And there was no significant acute change in PO2. What's often overlooked from that report, though, is that ECMO use was 80% in the NO group and 54% in the control. They actually did worse if your marker of doing worse is going on to ECMO or dying. Well, that's really interesting. Why would we be making them worse? So the lack of response to pulmonary vasodilators in the first hours after birth, I think, is more likely due to left atrial pulmonary venous hypertension than functional changes in the pulmonary arterial vasculature. And I'll try to convince you of that. So what we often see in babies with severe CDH in the first minutes and hours after they're born, and I'm talking about the first day or 2 of life, I'm not talking about 3 weeks of age, is we see a left to right atrial level shunt. And at first we were a little bit surprised by this, but it became clear that there were there are causes for LV hypoplasia and systolic diastolic dysfunction and CDH, and increasingly in the recent years, people are starting to pay a lot of attention to this problem and identifying it more commonly. What's the evidence for this? This goes back decades, right? Siebert reported in the Journal of Pediatric Surgery in '84 that in 8 newborns who died with severe left-sided CDH, they had decreased cardiac mass due to hypoplasia of the left atrium, ventricle, and ventricular septum. So we focus on the pulmonary vascular component and on the pulmonary hypoplasia, but increasingly there's evidence that the LV plays a critical role as well. In fetal CDH, Crawford studied 19 pregnancies complicated by fetal CDH and looked at cardiac ventricular disproportion. That is a relatively small LV compared to an RV by fetal echo. When they found that early in the course, it was associated with 100% mortality. Developing late in the 3rd trimester had a much better outcome. Probably this is related to the severity of the hypoplasia as well and the severity of the disease. Steve Baumgart years ago showed that in well infants compared to non-CDH babies or non-CDH ECMO-treated babies, CDH babies had a markedly lower LV mass. He looked at this cardiac angle, which was how much displacement there was with left-sided diaphragmatic hernias in terms of the relationship of the interventricular septum to the spine. And the more displacement there was, the worse was the LV growth. Rüdiger Stressig probably did some of the most interesting studies on this by fetal studies. And he correlated the degree of liver herniation with preferential ductus venosus blood flow to the right ventricle rather than to the foramen ovale. So in utero, the fetus is designed to have the better oxygenated umbilical venous blood shoot almost as a jet to the fossa lumbus ovalis and across into the left atrium. There is both rheology-related and anatomically related changes in the fetus that allow that to happen. So if you can imagine you've shifted things all the way rightward, what that potentially does is change the orientation of the ductus venosus blood flow, going more towards the right atrium than the left atrium. And if you've ever seen a chest x-ray with a severe left-sided diaphragmatic hernia and a properly placed umbilical venous line, it really looks odd, right? But this is the course that the ductus venosus is taking to the IVC, to the right atrium. This is where umbilical venous catheter wasn't properly placed, and showing that in babies with diaphragmatic hernia with LV hypoplasia, that ductus venosus and the return of umbilical venous blood is markedly shifted because of the shape of the position, malposition of the left ventricle. And this is just another series of studies from Stressig looking at left CDH versus right CDH, and the fact that the LV-RV disproportion is much more worse in left CDH compared to right-sided CDHs. Vogel looked at prenatal and postnatal echo studies in 85 babies. They found that with mild to moderate left heart hypoplasia is very common among fetuses with left-sided CDH. But they tend to get better after birth. The more severe left heart hypoplasia was associated with an increased risk of mortality. And Byrne and Roberta Keller, again, looked at the left ventricle, the aortic valve, and Z-scores were proportional to the severity of left-sided defect, but not so much in right-sided CDH. And Gabriel Teat, studying here in his fellowship, some of you will be familiar with the echo data that he reviewed on 15 babies requiring ECMO with CDH and 29 not requiring echo. Using a technique called speckled tracking echocardiography, he assessed the function of the ventricles. And compared with the non-ECMO patients, babies who required ECMO had decreased left and right ventricular function by both conventional and speckled tracking echo measures. So there's not only an anatomic component to this, but a functional component to the left heart problems in babies with diaphragmatic hernia. So, in a way of an interim summary, I think there are structural and functional LV abnormalities that likely contribute to pulmonary venous hypertension in CDH. I think this chronic underfilling of the LV in utero is the most plausible etiology of the LV hypoplasia. Other arguments have been that there's external compression of the lung or the heart by the lung, or that there's decreased pulmonary venous return. They probably contribute to it, but the most plausible explanation when you compare right and left-sided defects is that a chronic underfilling of the left ventricle causes LV hypoplasia. This, of course, is incredibly difficult to study in critically ill infants. We can't take all these babies to the cath lab, so we have to do the best we can with echo measurements. So in this setting, this is supposed to be we have a platform problem. This is supposed to be an echo of severe tricuspid regurgitation, which of course we can use to estimate RV systolic pressure and compare that to systemic arterial pressure. It is not uncommon in the most severe cases in the first hours after a baby is born with CDH to actually see a suprasystemic RV systolic pressure by TR jet with a right to left ductal shunt, but a left to right atrial level shunt. Now, of course, if there's no other intracardiac shunt, if you have a pure left to right atrial level shunt, then your preductal PO2 is essentially pulmonary venous PO2. So that in some ways protects this baby from having severe desaturation. So the left ventricular hypoplasia and diastolic dysfunction causes mitral insufficiency, increased left atrial end diastolic pressure, and pulmonary venous hypertension. In other words, increased left ventricular resistance is one way to think about it. And increasing pulmonary blood flow doesn't really improve systemic oxygenation in that setting. In fact, it might be harmful. One of the reasons we started thinking about this is babies with severe CDH and LV dysfunction who we treated with pulmonary vasodilators and had massive pulmonary hemorrhages. We were trying to drive pulmonary blood flow into a left ventricle that couldn't accommodate it. So I think this is one of the reasons we focus on the importance of preductal oxygenation monitoring. Most all reports of gas exchange in OI and CDH babies are from a postductal site. Jason Geen looked at samples from a right radial or brachial arterial line compared to a UAC, and what we found was that there are striking differences, not just in PO2, but in PCO2 and pH between preductal and postductal samples. In other words, if we're making decisions for intervention based on a postductal sample, we might be looking at the worst case scenario. Maybe we could reduce some of our support if we're using preductal samples showing a more normal PO2 and PCO2. This is just one example of how difficult this can be to manage. This was a baby who was a perfectly healthy fetus with a diaphragmatic hernia. At 5 minutes after this baby was born, we put in an umbilical arterial catheter, we did an echo, and this was the bud gas, 7.07 PCO2 of 90. This baby has retrograde flow from his ductus to his arch. Functionally, this baby, who was a perfectly healthy fetus 5 minutes before, now functionally looks like a baby with a hypoplastic left heart. So this is sort of the worst case scenario. Now, after resuscitation at 30 minutes of age, when the echo is repeated, now he has antegrade flow with a normal pH and PCO2. This is from a preductal site, and marked improvement. The point is, treating this baby here with a pulmonary vasodilator would literally be like treating a baby with hypoplastic left heart, which we all know not to be a sensible thing. So to just summarize all of these interactions, we did a recent review of the LV and CDH in Journal of Pediatrics, and this is from that manuscript. I think this is much more complicated than I've always thought about it over the years until more recently. That is, we typically think of lung hypoplasia being the essential component and everything else follows. Lung hypoplasia with decreased phasic lung stretch and or compression of the lung, decreased surface area, poor lung recruitment. And the pulmonary vascular component, which we've always focused on, with high tone and abnormal reactivity, structural remodeling, decreased vessel growth. There's no question that those are important parts of this pathophysiology and management. But now I think we also have to function on this relative role of the left ventricle in this disease. With pulmonary venous hypertension, decreased cardiac output, both structural and functional changes in the LV that are very difficult to manage. Pulmonary edema worsening with pH drug therapy. So there are not a lot of answers here. It makes the whole problem more complicated and more difficult to interpret, I think. But it also helps me understand why there's a lack of response to some of these interventions and how we can use echo to monitor improvement over time so that maybe at 24 hours a baby is ready for a pulmonary vasodilator. Maybe it helps us determine the need for ECMO and how quickly we'd go on if there's not just severe pH and poor gas exchange, but hemodynamic failure from an LV that has both structural and functional changes. So you certainly, it would be reasonable to ask, is there any role at all for a pulmonary vasodilator early in CDH? Now, I'm not talking about the 24-hour-old baby or the 3-week-old baby. I'm saying in the hours after a baby is born. I think there is. I think there's a role for stabilization and preparation for ECMO. Certainly, if you have marked preductal desaturation with a right to left atrial level shunt, those are babies we treat immediately with NO. And treatment of pulmonary hypertension as LV performance continues to improve. So the take-home lesson from this is that I think we need to consider all of the components of the pathophysiology of severe PPHN as a syndrome in babies with CDH, including the pulmonary vascular, pulmonary parenchymal, and cardiac components of it. We do not have a lot of great tools to address that, but I think that it does help us understand acute deterioration in babies with CDH today. Thanks.
Thank you, John. Any questions from the audience about? Well, it looks like we may be able to go to lunch. I'll ask him some questions at lunch.
Okay. Thank you all.